Good afternoon, everyone. I'm John from HTN, and welcome to this webinar today on electronic patient record systems with a focus on adding value to your EPR and EPR optimization. And I'm pleased to welcome a panel joining us today. We will have Pete Kendall, the Chief Digital Information Officer at Sheffield Health and Social Care NHS Foundation Trust, joining us shortly. We welcome Paul Charnley, the Digital Lead at Healthy Wirral Partnership and the Chair of the NHS England Blueprinting Programme. Kelvyn Hipperson, the Exec CIO at Cornwall and Isle of Scilly ICB and Royal Cornwall and Cornwall Partnership Trust, who will be joining shortly as well. And Dennis Rausch, the Chief Medical Officer at Dedalus, and Dennis will be chairing the session today and steering the questions. So just before we kick off, there are a couple of housekeeping things to cover. This session will be recorded and there will be a write-up from the HTN team, so you can read or watch the session back at a later date and share it with your colleagues. And there's an opportunity to ask questions today through the session, and we have a planned Q&A towards the end. So ask any questions you like. To do so, type them into the chat functionality of Teams, and we'll keep an eye on them as they come in. So that's it from me. So Dennis, I'd like to hand it over to you if you're ready.
Ready and willing. Hello, everybody. Good to see you, and yeah, happy to join you today for this, I think, very interesting topic. And yeah, before we spend much more time in introductory discussions and propositions, I would just plunge into the session directly and ask a very simple question, but maybe we can do one round around the panel, and it's: what is EPR optimization to you? And if you want to take it, maybe Paul, and give us your view on the topic.
Thanks. I mean, it's about making the best use of what you've got. I think there's two ways of looking at optimization. One is a top-down view, where you look at the organisation strategy and its objectives and the functionality and capabilities it needs, and then compare what you've got, the gap analysis, to what you feel you need to deliver your business, and then another view is to take it from a bottom-up approach, and there are a number of checklists, if you like. One particular one published last year was the NHS England's productivity playbook. And the back pages of that, in the appendix, is a whole checklist of the sorts of things that people have looked to include in order to optimize their EPR. I think some of the key features are around usability, the user interface, the ergonomics of it, so it doesn't get in the way of things. It supports an optimized EPR supports what clinicians want to do, and it isn't a frustration. And it's almost invisible in the way the organisation works. So there's those two things. There's the view from the strategic objective of the organisation, and then there's what have we forgotten? What do we need to do to make it work? And in the middle, just making the best use of what you've got, making sure it's adopted well, people know how to use it, and get the best experience from it.
That's a very good overview from your side, and couldn't agree more with the things that you already listed. So I don't have the full overview. John, maybe you can help if our other panelists have arrived in the meantime.
We're just trying to get Pete and Kelvyn on, so we're just speaking to them in the background. So hopefully
we just discussed the two of us. That's also cool.
But now, yeah, we apologise. We're trying to sort it. So
no problem.
Soon. Thanks.
So when you said making the best out of the things that you already have in place. So at least from what we have seen in the past decades being done on EPRs and the basic principal concepts that have been applied in the design and in the, as you say, the ergonomics. I think we all agree that it's not there where we would like to see it. And I would be interested how you see your way forward from the existing tools and systems that you can implement in a trust or in a hospital towards more ergonomics, whether this is all depending on, let's say, fundamental redesign of the software, or if you can do things also on your side through configuration or integration of systems in the right way.
Yeah, I think there are elements of the build in the absence of experience where you're doing it for the first time. You tend to perhaps over-engineer the solution and the amount of data that you're trying to create. Users. So there's an element of streamlining the configuration to get the best balance between compliance in terms of data capture and so on, and the ease of use. I've been working on our first EPR at Wirral was in 1993.
What?
And when we first designed a urine sample screen, the microbiologist wanted 12 pages of questions to be filled in, whereas the junior doctor just wanted to say it's a urine sample. And gradually over time you get to the best balance between the two, but you don't know before you go into it. And then when you look at what data is used after you've collected it, it's quite often things that are either not used or the data quality is so poor because the doctor's just hitting the first or default option to get through the workflow. So I think there's an element of streamlining what you have. I'm sure it's all right to mention the class questionnaire, KLAS. Wirral was one of the first to do it in the UK, and it was shocking. Only mitigated by the fact that the North American experience was equally shocking, that less than half of the clinicians using EPRs were satisfied with them, and we were no different. I think ultimately we need new user interfaces, the UX view of the solutions, but in the meantime we can certainly make it a little smoother. And cut out unnecessary steps and consolidate solutions. So there's jumping from one solution to another, which also creates a big, a lot of friction and energy being consumed by the user, because they're having to remember, I'm at this hospital today, I need to do these things, and then they move and they have to find a new way to do the same thing as well.
All right. And so when we look at your current assignment and your current position, where are you on this journey now? So when you think about where you want to take it, first steps?
I'm hoping to be on my way to retirement. As John mentioned, I have a part-time role, which I've recently started to step away from at a partnership level within Wirral. Wirral has a hospital, 50 GP practices, community trust, a mental health trust, and they're all separate. And having been the CIO at the hospital, I saw my role as being helping the glue between the different parts of the system. And social care was also part of this partnership. So one of the aspects I think of EPRs in the future will be that they are either a seamless piece of a system-wide solution, or they are a system-wide solution, and that is a development from each organisation having their own EPR to being able to interoperate and manage in a patient-centric way rather than an organisation-centric way. So we haven't got one EPR for all the organisations, but using shared records, we use Oracle's Health Information Exchange between our partners. It starts to feel much more like a single record, if not a single set of processes. And I think that's one aspect of where EPRs need to go is into that system level patient-centered approach. So we've had Millennium at the hospital for some time, but we have TPP in community, we have TPP in mental health, we have EMIS as our GP system. So pulling those groups together, I think, is something that I've been spending my time in the Wirral Partnership to try and achieve. My other role is as the chair of the blueprinting programme, which began with the digital exemplars. When money was invested from the centre, we were looking to get blueprints from all of the exemplars of what they'd spent the money on and how to repeat it more quickly with other people. And I think there's one thing that we don't do very well in terms of optimising EPRs is we all do it ourselves. And we need to start to learn much more from each other and share the developments that we use to solve the same problem, but it could be in 20 different ways. I'm glad Kelvyn's arrived now. I can be.
Yeah, I'm very sorry,
Kelvyn.
everybody.
Yeah, we're also happy. Good to see you. Hello, Kelvyn. And yeah, I give you a break, Paul, and maybe we can come back to part of your comment just now. After Kelvyn has given us his perspective on today's topic, so EPR optimization. What does it mean to you? How do you interpret? What is your idea about that?
Yeah, so I guess really the big thing for us in Cornwall, I think Paul was probably touching on some of it just as I joined, is that we're viewing EPRs in the broader sense of where they're used across all the care settings. So I've kind of got a little concept diagram I put in front of people where I talk about, EMIS and TPP in primary care, their EPRs, our Rio platform in community mental health, and we're just in the implementation phase now for Oracle Health Millennium in the acute, and that's a massively important piece of the jigsaw because it's been a barrier to effective join up across all of those capabilities because we've still got hundreds of individual platforms in the acute setting. But taking that even further, we're working with our council colleagues around their platform in adults and children's social care, and actually really interesting conversations with our third sector colleagues, and potentially linking in their case management platform. So for us, EPRs are a really important part of the ecosystem, but we absolutely are viewing it as a whole ecosystem.
All right. So the scope that you see is much wider than this, and I think that resonates a little bit with what you just said, Paul, that you on that level, using, I would say, a very technical level, but still were aiming and successful in creating a shared record at least. So when we look at that progress that you already made, Kelvyn, what's the main challenge, or what's the point where you are standing on that journey? How far have you gotten in getting these things together?
So again, I suppose you could say, I hate to use the word, we're doing it in an incremental way because it doesn't do justice to any of the individual programs, but we have been incrementally building capabilities with that view to the long-term goal of how they're all joined up. So in community mental health, for instance, cleaning up past. It's funny actually, within the NHS, you kind of think something's implemented cleanly. Very often it's not. So we had more than one instance of our platforms there. Those have all been brought together. We had 3 different GP systems. We've consolidated down to 2. So things like that have been progressing. As Paul was saying, we've implemented our shared care record. We've done that jointly with our colleagues in Devon. So we've got a common platform across the 2 counties. So that's with an eye to patient flows between the 2 counties. And then really kind of the layers above that around, we've put in a referral management platform so that we can move patients as smoothly as possible between the different care settings. None of this is all the stuff we all talk about in the NHS, patient portals, And sitting above all of that and drawing all the information out into population health management. But they kind of, as I say, they're growing incrementally, and then I've seen this before with very large scale transformation. You spend years doing this stuff, and then everything comes together, and then there's a massive change really, really quickly when all the right enabling capabilities have all come together.
Keyword change, I think that is also something that is very important if you are trying to tackle that endeavor. How do you guys manage it to get on board your employees, your colleagues, the different aspects of providing leadership in such complex projects? How have you been approaching this in your situations? Maybe over to Paul once again. Are you muted, I think?
So I think in my early days, as I said, we implemented our first EPR in the 90s. It was a fairly IT-led thing just to get a basic solution there, but I don't use the solution, and I'm guessing Kelvyn doesn't either. So having good clinical leadership and operational staff, even receptionists and medical record staff who are very fundamental sometimes to success, is the key to success. Is to be that person that only gets noticed when something isn't working, and let everyone else take the lead in terms of what the systems need to do for them. And I guess in the last maybe 5 or 10 years, we're beginning to talk to patients about what they'd like to see too, and that can only be a good thing. So it's not about consulting with them; it's empowering them to give us our priorities and to shape the solution. So I've been lucky enough to work with some really fantastic chief clinical information officers, now chief nursing information officers, chief IOs in pharmacy and in allied health professionals. And I think that is a trend over those last couple of decades particularly, which is helping to improve the quality of the solution. We also try to engage across the system now. So we ask GPs about our discharge summaries from the hospital. I don't know why we try and design them from the producer's point of view and not the consumers. So it's not a highly technical thing, but it's about creating the environment in which that happens. It's a bit tricky at the moment. People are very much overwhelmed by the amount of pressure on them outside of the digital world, but we have managed to conserve clinical input into the system because I think people see it as the way we do things.
Maybe just one question directly on that. So when you say those chief nursing information officers and other ex-information officers, are those dedicated positions, or is this more a role that clinicians take over next to their activities?
Yes, but we give them space. I think they don't want to leave the clinical arena, and they have more credibility because they're using the things day to day. So there are no full-time CXIOs in the patch, but we do give them funding for sessions when they're doctors, and hours in the week for the others. In fact, no, that's not true. The CNIO is now pretty much full-time on that, because I think that the nursing hierarchy sees that as an important aspect of nursing.
No, that makes sense to me. I guess to most of the people, we know how difficult it is to understand the medical piece of IT and the other way around, and to help engineers to build it in the right way. Kelvyn, what about your side?
Yeah, so I absolutely recognise all those themes that Paul's just outlined. So very similar. CNIO role is a full-time role. In fact, we've just, because a lot of people bunch into CNIO, also the clinical safety officer role. We're separating that because we've recognised actually even that's too much. CNIO absolutely needs the space to be focused on that role. I think as well that there's a really wide variation in kind of knowledge and skills in this. So some teams we work with they're so easy to work with. They know what they want. They've got the skills almost to deliver, and actually the partnership with them works really smoothly. It's harder when something is so new and alien to people. Yeah, it's just too much to expect. There's no good going and say, "What do you want?" Don't know. So some of what we've been doing is, again, some of those incremental projects is very deliberate around gradually introducing things, and then as people's knowledge and experience grows, you can see the light bulb starting to come on, and then they start to drive it. So the kind of the goal is eventually everybody's in that position of driving, and actually my life is really easy. So I've been working on that for umpteen years. I haven't quite got there yet, but another thing that's probably worth highlighting is that I joined the NHS from another sector, and the whole kind of CXIO model in the NHS is brilliant. You go to any other sector, the best you're likely to get is somebody's notified or told you're going to be the expert user, and they say, "Oh, that's nice. Where am I going to fit that in the rest of my job?" So to actually have these as defined roles, and actually the thought's gone into the skills you need for the role, and that kind of joint working across clinical areas alongside technology is brilliant. So we probably don't shout enough about that to kind of really say this is actually something really good that other sectors could learn from.
All right. I think there's linking into that. There's a question from the audience, us from Jennifer, who asked if we or you have any advice around getting that sort of feedback regularly from all staff across different roles and departments. So I think a little bit, how do you organize that? It can be a lot of sessions or discussions, and you have to somehow get it together and understand what is the resulting priorities for your teams, right?
Do you want to go first this time, Kelvyn?
Yeah, actually, so there's two dimensions to that. There's again, people tend to do that quite well in a big program. As you say, they organise all the workshops and things, seek all the input. I think the trick is finding ways to carry that through into the operational service delivery. And something our teams do is actually your kind of technical engineers that support staff. They're a great source of intelligence. We kind of do ward walkarounds. And actually our training team now have started doing the same kind of concept. So the training team will go into different wards and just say, yeah, anybody got a problem? So I think using all of those sources of feedback is really important, because otherwise people just sit on problems and grumble about them. And I always say, feedback is the lifeblood of what we do. I don't care if it's a positive bit of feedback or here's a big problem. I just need to know, because we can't fix things unless we know.
I mean, I would say there's a formal feedback structure. Our digital program board has transformed itself into a digital services board, where we account for our service as well as for our delivery of project deliverables. And I think that helps us in a more formal sense to understand where we sit. That takes its place in the whole hierarchy of trust governance. I agree. There's lots of softer, informal feedback you can get, and one of the things that's probably in people's minds right now is the digital maturity assessment feedback. And the key there, I think, is not for people like Kelvyn and I to sit in the room on our own and sign it off, but to get people's opinions of where we are on those questions too. And it's something that is only really valid if it's something the organisation has completed.
Right, thank you. There's another question from Nicholas, but I'd like to first take the following one, which is about how do you best deliver the training on the EPR, because it links also to that connection with your users, right? So is it more like modules that people do themselves? Should it be face-to-face? How do you organize that? Maybe Paul.
You want to go this time, Paul? And then I'll follow.
Okay, yeah, I mean, I think it's changed over the years, and now a blended mix of reference material and online training, and classroom work is very much to the fore. I also recognise there's been a change in that it's not my department that trains people in the use of the system. The midwives train the midwives, the pharmacists train the pharmacists, and the doctors in prescribing. So it's become training in the way the hospital works, not specific EPR training. And that's far better. There was a time when we didn't trust people to teach them how to use the IT. But when you appreciate that this is how they're doing their job, it comes across much better from those colleagues who are showing them how to do the rest of their work that's off the computer as well. I think our department's job is to provide the raw material and the videos and the screenshots and all of that to help with the material. But more and more we're letting go of the training internally and effectively accrediting the departments to look after themselves. I felt better when I was in the CIO role after a while that was a better way of doing it than trying to keep it all to the digital team to make it more about which buttons to press. If we did it, it was much more about how to do the workflows when the departments took over.
Okay.
Yeah. So I know what doesn't work, and it is, I think, that traditional model of you've got a program, you've got your go live coming up, and you tick off that this many users have been trained. Well, you're good to go. Generally you're good to go for a little while, but the skills fade. The things that people didn't pick up in that short training course they did, are the things that caused them pain. Which is why I'm really pleased, as I say, that our training teams themselves are getting out there more. We certainly need to do more around colleagues, I think, doing that training. There's a tension there, though, of course, there's nowhere where it's around how much of that can they take on when we're already asking them to do a lot clinically. So we've certainly got digital clinical staff that support people as well. But increasingly, I think it is the delivery of training in the places that people work. I keep threatening to hand back all the training rooms to force it to happen.
Right, and another training question, and then I think we switch the topic, but I guess this all also applies to the shared record, or do you do any distinction whether training people to work with the shared record or with their own EPR?
Well, we just trained it in the various roles that we trained within each of the EPRs and in primary care and in the community. It's not something we train in separately.
So you don't do by system, but their workplace, so to say.
Yeah.
Right. Okay. Right. Then let us come back to the question that I parked for a moment. So I think it's nearly a philosophical question when it comes to designing health IT. We know that there's a lot of impact into clinical documentation that is not motivated by clinical reasons. Yeah. So be it for statutory or billing purposes or whatever quality management systems that might be interested in data that is not relevant for taking care of the patient. So what is your experiences on balancing or finding the right balance between asking clinicians to provide information and data that is actually not their direct concern, towards not, let's say, ending up with not having the information that is probably mandatory even. And Paul, you start.
Okay. As I said, that's something that you end up sanding down the rough edges and trying to make it as easy as possible. I think one of the things that infuriates people is asking them a question the computer already knows somewhere else, and or another computer next to it knows. So I think questions of interoperability and the kind of data model that leads to one concept being collected once and stored and then retrieved when asking further questions, rather than this is a separate template, you've got to fill the whole thing in, regardless if we know the answers to half of it, because we want this contemporaneous single piece of information to be collected right now. And yeah, I've seen systems designed to collect the paper that's been designed on a form, not broken down into, well, when is that information available? Can it be collected from another transaction? So I think there's some of that design ergonomics I was mentioning earlier that helps, but ultimately, audit data sets, national data sets are designed by committees which do include clinicians, etc. And it is our job, and I have an NHS England's role as well, to try and satisfy those, because there is a professional guidance to these are the things we need to know about these sorts of conditions or patients. So in the end, sometimes it's about, well, it's mandatory. We're going to have to try and find the easiest way for you to do it.
Kelvyn.
Yeah. You did pose it as a bit of a philosophical question, because I think there are some really tricky philosophical questions around it, because I've seen both extremes. More often than not, you do end up with it being overcomplicated, and the reasons for that are completely understandable. Clinical colleagues are worrying about legal ramifications of things, what it might mean for them as an individual, and I completely get it can be a very lonely place for a clinician when there's somebody in front of them and they're collecting information. But at the other extreme, I've seen some instances where something's been designed locally by one or two clinicians, and because they feel really confident about what they're doing, it's really, really lightweight. And in fact, we're almost questioning it from a kind of safety case management point of view. But I think on balance, there tends to be more of a pressure towards overcomplicating these things. Some of the philosophical responses to that, because I don't have a perfect answer by any means, is I still feel strongly that kind of a multidisciplinary approach to kind of questioning this and actually almost a lot of the clinical situations, because actually there's strength in a group of people deciding things as opposed to somebody feeling all of the accountability and that driving them towards going to the nth degree with it. Because again, the other aspect of the tension is so much of clinical training is geared towards trust your judgment and the information you gather. Even though we're quite often now sharing information, I think there's still a tendency to recheck it. As I say, I came from other sectors years ago. I used to work with cartographers, and their whole training around their world was don't trust anybody but yourself. So they were a really tricky professional group to work with. So again, I think there's that element of somehow we've got to get into the space of our relative professions, technology professions and clinical professions, almost meeting up at a much higher level to tackle some of these deep philosophical questions about how do you capture information in a way that protects the individual and the people they're serving.
So if I try to summarize a little bit, for you, one of the key elements definitely is to have a close connection and good listening towards the users and to work with them together to understand how you can get the compromise best done to combine those different needs towards the software, sometimes conflicting needs even. So when we look at that, are you facing qualification skills issues in your workforce when it comes to using IT systems? Apparently, there has been a study or report this week that's coming through the chat where that is sort of raised as a problem in the nurses in, I guess, in the UK. I cannot judge on that.
I'm certainly aware that there's a leaked report floating around. The themes in it are kind of common themes that have been around for a long time, around shortages of skilled people, and again, actually those shortages exist across many different sectors, so it's not unique to health. That's definitely one area where we've got a lot to do in terms of the usability of the platforms that we use. And actually, I think providers are starting to wake up to that. They're starting to recognise that the sorts of usability improvements that have been made in other sectors, I think some of the usability improvements that can come with careful use of AI and automation, we've got to go down that path, because expecting everybody to be a deep technical expert is just not reasonable.
Yeah, I'd agree. I think every workforce in every sector will have people who don't have the digital skills. I don't know if the caring professions tend to attract people who are less interested in some of the digital technologies. But it's, as Kelvyn says, we introduced Welsh LN machines connected to our EPR for vital signs, and there's a barcode and a barcode for them. And if you can make those transactions for the staff less technical, then they're easier to adopt, and that saved lots of time every time a vital sign was taken. So they were motivated to use the technology. And if we're trying to put stuff in that doesn't give them those sorts of benefits, then I don't know what digital skills we're expecting people to have as well.
Yeah. No, I mean, from my perspective, we've seen big changes in that basic skills of using IT also since iPhone and smartphones are out there, right? So people are using IT every day. That was not the case when you started or when I started health IT management. And I think that is something where you can assume a basic level, isn't it? And if we design our systems in the right way, and I'm looking at myself also as being with the manufacturer here, we should see this as an ambition. So what is happening in consumer computing, why would it not be possible to have similar usability and UX in professional computing one of these days?
Yeah, and we're seeing some of that from the public. So kind of busting some of the myths for our patient portal. The take-up rates are very high, pretty much across the age ranges. There's only right at the very top end of the age range it drops off a bit, but actually doesn't drop right off. And again, some of the greatest amount of use in our most deprived areas, both of which I've been in umpteen meetings where people have said, "Oh, well, digital exclusion, you can't possibly do this because of digital exclusion." And again, our kind of unique thing down in Cornwall, if I believed everybody who said there's no coverage in Cornwall, there wouldn't be a single person with a smartphone. So sometimes you have to push back on these things. They're kind of rooted in an intent that's right, but actually I think you've got to embrace the fact that this is coming and never going away.
Right. Maybe to come back to a topic we discussed before you joined, Kelvyn, and Paul brought it up, that it's so difficult, or that you're basically doing things that others already have been doing because you're solving the same problems. and it's more motivated by the local, let's say, ecosystem of solutions that you have to do it again. And even in that, if you look at your organization, there are usually harmonization challenges. For instance, you know that this specialty, this department definitely needs a different assessment form than this department, while you don't want to voice it open, but everybody knows they don't. So how are you tackling this? How do you leverage synergies in creating these documents, forms, and content artifacts between different specialties departments?
So certainly for us, we just keep saying all the time, we'll tap into best practice wherever it is, and as I say, we're in our acute EPR implementation now, so we're kind of trying to build links with other hospitals that much further along the journey, and actually kind of ruthlessly reuse what they've done. The kind of uniqueness question again exists. It doesn't just exist in health. It is particularly strong thing, I think, in health. But actually, most places you go to, the only thing that's unique is that it's a unique combination of similar things in that particular place. So generally, you can identify where there are key themes or common themes, work with those, and then rather than actually kind of really bespoking things, it's can you do a little bit of a tweak just to suit some of the local need, but constantly mindful of the more you bespoke stuff, the harder your life gets. And actually, people don't thank you for it, actually, in the long run. One of the things you learn in project management is the project manager who says yes to everything is the one who actually has the biggest problem when they go live.
Yeah, they'll be popular for a short while, but then less popular. I think there's one thing I've been a bit disappointed in terms of each of us doing our own thing. Wirral had a fairly has a good, but it's not as big as it used to be, development team for bespoking the Cerner templates and so on. But then trying to translate them to Oxford or Berkshire or London or wherever else, it just became difficult to fit them into those solutions. And some of that is about us not, taking our EPRs and spreading them out in less than uniform ways. And I think there will be a move for us to come back to sharing the development of these things between organisations and implementing them, because we each can't afford to have that size of team, not only to create new things, but every time a core upgrade to the EPR comes along and you've done a lot of these configurations, you've got to test it all again. And the more you have, the more you have that kind of inertia. So I think there's definitely a case for us sharing developments rather than, well, I know what to do, we'll go and do it here, because then in your local control, you know how, you potentially know how to do it, but it just creates these little pockets of uniqueness. We've had umpteen discussions about how to record smoking behaviour, as an example. How many packs, cigarettes, micrograms of nicotine, just coming down to something that's comprehensible between all of the different people. There's one last thing, but trying to do a common assessment between professions in social care, community nursing, the hospitals, and that's still defeating us. So it's not just a problem within one EPR, it's probably even bigger when you try and get one document that's common. And the other one is the EPACS end of life documentation, which floats between organisations. I think we've still got work to do there to make it easier to move these things around and standardise on them.
Okay, I think that's a good point. So initiatives like OpenAir, Open EHR, does that play a role in let's say your vision on how this collaboration could be resolved in the future and get better?
I think, probably unfortunately, that there's a significant inertia momentum behind the monolithic EPRs, which the purer idea of having componentized elements that you can switch in and out kind of forces you away from that kind of models, trying to include everything you've got in your EPR if you can, and only by exception adding other pieces to it. And it's a case of, starting from here, where you would go, as opposed to where you might end up in, if you were able to decouple this monolith and build it to the open EHR type standards. But I think the answer for us, Cheshire Merseyside at least, is the layer that sits between organisations is where you can start to use that open EHR stuff and adapt your local EPRs into that frame over time.
So do you agree? Different view.
Yeah, I'd have actually quite similar view, because again, standards-based approaches work best, really, as Paul was alluding to, when the standards kind of drive the whole of a sector from its outset. So, the reason we all use smartphones is because, that's been managed in a standard at the net infrastructure levels, in a standards-based way throughout. So trying to kind of reverse engineer open EHR into a very commercial world is difficult. I think the pressures of the market will see greater interoperability, whether that's the open EHR standard or other ways of interoperability. I think be a bit of a wait and see on that one. The problem you have, and we've just been through it, obviously having just done a big procurement exercise. We've been in Cornwall, we've been wanting to replace our EPR for 20 years. Well, sorry, so we didn't even have an EPR, so we wanted to replace our PAS for 20 years. So the fundamental approach to the whole programme has been one of, it's got to succeed. And so, the whole procurement strategy around something that's proven, you can run a competition to get something that's affordable, all being geared towards, it's got to happen, because 20 years on, it can't not happen. So nice though, open EHR as a concept, I don't see too much out there at the moment, which is well, we could have gone out and bought something that fully complied with that. There would have been so many compromises, it would have been a challenge.
Thank you. Right, so we don't have so much time to go, but I would like to ask one more question also from the audience. So imagine a greenfield situation, and with all your experience and lessons learned, so you have set up that small shack of a core PAS system. So what would be the optimal sequence now to proceed? What kind of systems would you introduce step by step? And Kelvyn, maybe you just continue.
So it's a kind of your hypothetical in an ideal world. I would probably not even start in any of our clinical settings and actually start with the people that use our services. Because it's fair to say, one of the further out, more out there concepts I talk to people about around our health system is I want to turn it on its head. And for actually all of our services to be in the service of the people who use them, whereas we're still, in the traditional model at the moment where, our kind of organisational things tend to drive a lot of what's going on. So, if I ever had that greenfield hypothetical opportunity, that I'd start, as I say, at the other end.
And I would say it's the electronic patient record bit of it is going to drag you into a way of thinking. I think identifying people and their relationships to each other and their proxies and all of that, identifying scheduling capability that's organisations independent, identifying the transactions that are needed to move data samples, work steps through and between organisations, and the open EHR record in terms of a core record is probably part of that, but it's trying not to create too many boundaries around it that would mean that it cannot reach to community of interest companies that we're now trying to work with, or the individuals and their families, in a much more open way than we can do now. And then, layering that into the analytics tools that need to be much more at the real-time data, at the front end of things, rather than being more retrospective as they tend to be now.
Right, thank you. Okay, so I also brought my crystal ball, and I think we should take a round and just try to look through it and learn from you. What is your vision? What is your idea? How could that health IT computing change in the next 10 years? How do you figure an EPR, if it still exists, in 10 years' time? What is your best idea what could happen there? And Kelvyn.
Yeah, as I said just now, the ambition is to turn the service on its head. And kind of what I mean by that is, really, I think what's coming with AI is your interactions probably will be predominantly with AI to begin with. Are you well and healthy? And and that kind of giving you that assurance that you are. When something happens, I think in many instances, advice that would allow you to perhaps resolve things yourself, so that actually the kind of current default of pick up the phone at 8 o'clock in the morning, in a sense, becomes more of an exception, where those capabilities would make an appointment based on the information that you're providing. I think there will still be things like EPRs managing the work within the clinical settings, but really, as Paul was just outlining, that they'd be much more integrated into that ecosystem, where rather than the work kind of originating out of the clinical setting, it's coming in from the needs of the people that use the services and servicing their needs. I'm setting that out as probably the most out there view of the future that might be. I'm getting on past history of transformation, which is, if you're kind of that far out there with that, you won't actually land at that. But actually, if you get somewhere near it, you're a lot further on than you are today. And that, the trials and tribulations that we're going to have getting there as well are kind of part of what makes working in this profession such an interesting and rewarding thing. So, I mean, I'm still saying about our EPR work, it's going to get harder before it gets better. But it's worth doing that because you're aiming for something better in the future.
Yeah,
that's very interesting.
It's kind of entertaining to think about what it might be like. I don't know how long your contract with Oracle Health is, Kelvyn, but ours is till the 2030s. So in some senses, we're working with what we've got, and I think transferring from one EPR to whatever's next is not something you could do in one step. It's like a brain transplant for an organisation. It will be really need to be in chunks rather than trying to do the whole thing. So I think EPRs will exist into the future, as Kelvyn was suggesting. I grew up in the 70s. There was a program called Tomorrow's World. Some of you may still remember it. Well, they used to try and predict what was going on in the future. In the 1970s, they I've got the book from back there, and they were predicting there would be a worldwide computer by the 90s, which is pretty good going. They also predicted there'll be a cure for cancer. But if I think about the 40 years of my career and the changes in health informatics over that time, I don't know what to predict for the next 10 years. It does feel like a disruptive period with artificial intelligence. It probably take longer to get there in a good and safe manner, but it will look, it could look quite a lot different. So it's about trying to work with these big machines that we've got that will keep the transactional part of healthcare moving, whilst trying to change the way in which services are delivered to be more preventive, more proactive. And I think population health management aspects of what we do, and potentially how we have to ration services as the generation like mine gets to be elderly. In 10 years' time, there'll be more of us. I think there's going to have to be some elements of using the technology to make our resources fit. So those are some of the things I think we'll see. But really, I'm not sure we can predict 10 years ahead these days.
No, I don't. I will not hold you responsible if it doesn't occur. No, but I think we all agree AI is here to stay, and it will change a lot of things. And if what I sometimes do, I transport myself back 10 years before, and if you see what happened in that time, I can only agree with you. Prediction impossible.
Yeah.
I'm very eager to learn how quickly we will really see productive and, as you said, safe solutions based on AI, beyond those, let's say, I would say marketing motivated little pockets of, wow, look at what is happening here. When does it really enter production? And my gut feeling is that can be very, very quickly, because of, let's say, simply the size of the amount of people working on it. So we see that worldwide, there's not one IT company that is not looking into using AI for their products and portfolio.
Yeah.
So it can be very surprising.
The light bulb went on for me actually a little while ago when I made the connection. Actually, so much of healthcare delivery is talking to people. And what's the most sorted aspect of AI?
Yeah.
Voice recognition. So I know there's a big leap from that to a reliable diagnosis. That is a really tricky problem. But I think there's a lot of what we do that involves talking, that actually is kind of getting to maturity now. So I think we're going to see that shift quite quickly. And then, as I said, the tricky bit is going to be the kind of step into the diagnosis world. And as I say, kind of thinking back again to the world of cartography, that was really interesting, where cartographers said the computer can never ever make a mistake. It had to have I said, I'm not going to give you a 100% accurate system. And then when we looked at the human error rates, people were very relaxed about that. So again, there's kind of different perceptions of what's safe and what's not.
True word. Right. I think we're nearly on top of the hour. John, what's the plan?
Excellent. Well, thank you all for that session. It was great, and thank you for taking the time to join us. We will be doing a write-up of the key discussion points and sharing that so people can read that back. And thank you to everyone for attending as well. So if you have any questions outside this call, feel free to email me at john@htn.co.uk, and I can help connect any questions outside the call. And I also want to mention the NHS Futures platform. There's some great resources on there around EPR best practice, and visit the Futures platform to access those. So yeah, we are up on time, so let's close the session here. Thanks again to everyone for attending, and thanks Paul, Kelvyn and Dennis for this session. We really appreciate it. So thanks everybody.
Thank you very much.
Have a nice day.
Bye.
Cheers. Bye.